All right, we can go ahead and get started. Would you mind going to the next slide, please? All right, welcome everyone. Thank you so much for joining us for another episode of the group chat. Just to go over a few housekeeping items before we start. There will be a Q&A at the end of the presentation, so you'll see a little Q&A button on your screen. Feel free to submit questions there throughout the presentation. I'll compile them on the side and then ask our speaker at the end. The presentation is being recorded, however, no attendees will be identified. And as a reminder, the information shared during this presentation is not medical advice, but we will be providing additional resources at the end of today's talk. And with us today, we have Dr. David Stapor. Dr. Stapor is a board-certified orthopedic surgeon specializing in adult reconstruction. He is a physician champion for the AHN Osteoporosis and Fragility Fracture Program. Today, he joins us to share his expertise on osteoporosis and how you can stay on top of your bone health. We're excited to have him here with us today. So with that, I'll pass it over to Dr. Stapor.
Good morning or good afternoon. I am an adult reconstruction orthopedic specialist, but I'd be probably classified more so now as a bone health and osteoporosis fragility fracture expert. So osteoporosis. Gave some sample questions, and I'm going to try to answer all these questions for you today. I may not do it in order. But I think I'll get to all of them at one point or another, and then we'll review at the end. And certainly I have time for all and any questions because it's a confusing topic. It's poorly understood. I'm going to give you a little bit more insight today into all the nuances of osteoporosis. Number one is people get osteoporosis and osteoarthritis confused all the time. Osteoarthritis is a condition of bones and joints that produces wear and tear, typically associated with deformity, pain, limited mobility. Osteoporosis is a bone disease that develops when bone mineral density and bone mass decreases, or when structure and strength of bone changes. And this can lead to bone strength, which ultimately can result in fractures or broken bones. Osteoporosis is silent, and that's what's important to remember most of the time. It's typically non-symptomatic unless you break a bone. Osteoporosis is the major cause of fractures in postmenopausal women and in older men. Low bone density. Low bone density is when your bone density is lower than normal, but not low enough to be considered osteoporosis. This may mean you have a greater chance of getting osteoporosis if you lose bone density in the future. This is typically detected through a bone density test, and we'll talk about bone density tests in detail. They've been around since 1987. They are not perfect. They measure bone area, grams per centimeter squared. So you're not looking at the quality of bone, you're looking at the density. They're a good test, but they're not the only test to diagnose osteoporosis. Typically, and I'll go over you can see understanding the bone density test on the bottom, but I'll go over that in a little bit more detail when we get to the next few slides. Men and women both build up bone till about the age of 29, 30 when you have your peak bone formation, and then you gradually lose bone over time. You can see the big dip in menopause for females. You lose about 2.5 to 2.5+% of your bone mass in the first couple of years after menopause. Men go down a little bit more gradually about 10 years later, and then men and women after the age of 75 lose bone at about the same rate. So bone is a constantly turnover system. It is formed of cortical bone and trabecular bone. You can think of the thick outer bone of the skeleton and the thinner cancellous bone or spongy bone. And this is kind of what it looks like here. The spine is a typical spongy bone, mostly trabecular bone. Cortical bone and trabecular bone are about half and half in the hip and then the long bone, sometimes cortical bone predominating a little bit more. Bone modeling occurs daily. You replace your whole skeleton every 8 to 10 years or so. So there's a constant battle between bone turnover, bone being made and bone being broken down. When you're 29 or 30, it's pretty stable. You're breaking down at the same rate that you're building bone, or maybe even making bone a little bit more. But then gradually the breakdown exceeds the buildup. And if it breaks down too much relative to buildup, then you end up with low bone density and risk for osteoporosis. So the cells are the osteoclasts. Think of it as like the Pac-Man cells that break down the bone. Osteoblasts are the cells that build the bone. Osteocytes are the orchestrators of bone remodeling process and bone maintenance of the bone matrix. They form, they're activated and they form osteoblasts. So an imbalance between bone resorption and formation can result in bone diseases that include osteoporosis. About 30 to 40% of bone is composed of collagen. It's a protein, and it provides the structural matrix about where mineralization of the bone occurs, like a 2x4s of a house. One of the common disorders that's associated with lack of collagen or disordered collagen is osteogenesis imperfecta, which some of you may have heard of. So here's the whole bone remodeling process in a nutshell. You've got resorption and then reversal with formation, followed by mineralization. And this is all through the osteoclasts, osteoblasts, producing the osteoid and then mineralizing it to get normal bone. And this goes on constantly. Sex-related bone loss. Females have greater bone loss in menopause than males until the age of 65 to 70. And then females and males both lose bone about the same rate after that. So men have hip fractures approximately 10 years later in life than women. Balance of endocortical. Remember, cortical bone is the thick outer bone, spongy bone, cancellous or trabecular bone is the inner bone. But endocortical bone resorption and periosteal new bone formation in men occur because of the effects of testosterone primarily. So the circumference or the width of bones in men increases and they have greater thickness of the cortex, and that results in greater bending strength and less of a chance to break bones. Postmenopausal women don't compensate for that. So the resorption is much more than the apposition. So you lose typically that trabecular bone on the inside the fastest. That's the spongy bone. You get thinning of the bone. You lose the connectivity, which is the way the bones meet together. And this is primarily caused by estrogen deficiency. So the spongy bone, the trabecular bone, it's like a honeycomb type network. You can see it on the slide here. 20% of the skeletal mass in your body is spongy bone. And think of the spine. High turnover rate compared to cortical bone. Cortical bone is the dense outer bone, 80% of skeleton mass, so it's much thicker. Think of the long bones of the skeleton, like the femur or the hip. The turnover rate is much less, and it provides most of the strength. This is a scanning electron micrograph, so you can get a better idea of bone quality, what osteoporosis looks like. The normal bone on the top, the osteoporotic bone on the bottom. You can see it looks like Swiss cheese. Not only do you lose the thickness, but look at the connectivity. There are gaps where the bone should be meeting one another. And obviously, if you step on something like this, it has a chance to break. So the architecture is impaired, the strength is impaired, and there's increased risk of fracture. So let's talk a little bit about DEXA, dual energy X-ray zoometry. It's high precision X-ray that measures bone mineral density and bone loss. Density. It's non-invasive, it's fast, very low levels of radiation. It's been around since 1987. It's the best technique we still have for assessing bone mineral density in postmenopausal women with osteoporosis. It measures and monitors bone mineral density in grams per centimeter squared, which is aerial. So it doesn't really tell you much about the quality of the bone. And this is how it's done. It is dependent on how the patient is positioned. We typically measure the femur, the total hip level, and the proximal femur, femoral neck, as well as the lumbar spine. The positioning has to be correct. The way the edges are marked around the bone need to be correct. Artifacts are a big consideration when you do this test. And what are artifacts? Things like contrast media. If you've had a previous scan of the abdomen with contrast, you have a big belly, pannus formation. So you shoot through that and it distorts the reading, especially in the back. Previous hardware placement, such as back or hip. Arthritis and fractures. All these could increase the density and give you a lower sensitivity or a better than anticipated reading on the DEXA scan. So while a DEXA scan is important, as we're going to talk about, it's not the only test. If you look at declining DEXA scan numbers or the T-score, And this is the actual reading in grams per centimeter squared. Every decrease of 0.1 in grams per centimeter squared is a 2 times increase in fracture risk. So DEXA scan, if it's done appropriately, is an excellent predictor for fracture risk, particularly when you get to the lower levels. Your DEXA scan is typically reported not only with the grams per centimeter squared, but something called a T-score. And the T-score is a comparison at the level that's measured to a normal 30-year-old person bone at that level. And the measurement is the standard deviations below that level. So say you have a T-score of -2.5 at the femoral neck relative to that 30-year-old person. That is considered osteoporosis because it's 2.5 standard deviations below the norm. That T-score of -2.5 corresponds to a level of grams per centimeter squared that is directly measured from the bone density scan that we can use in our analysis. So there's a clinical care gap. DEXA is highly underutilized. 10 to 12% of Medicare diagnoses. In fact, the results are still about the same. People that have had a significant fracture, only about 10 to 12% of them across the country get DEXA scans, and that's when you need them the most. They are approved for any woman 65 and older, any man for 70 and older, and if you have risk factors, you can get them done at earlier ages. Again, modest sensitivity because it's 2D, it measures area, so the T-score results are not intuitive. It's unsuitable for surgical planning, and it can be inconvenient to the patient to visit a DEXA facility, particularly after having sustained a fracture, though it doesn't take a lot of time to do the test. There's at least 25 million patients per year in the US without needed diagnostic testing for bone health. Basing treatment decisions solely on T-score and DEXA scan will miss over all those who will fracture. And again, we talked about one of the reasons that DEXA may not be quite sensitive enough in some circumstances to talk about bone health, but there are other factors to consider when you're talking about bone health and osteoporosis. The diagnosis of osteoporosis can also be made not only by a T-score of less than 2.5 at any of those sites that I mentioned, total hip, proximal femur, femoral neck, or lumbar spine, but anyone who sustains a hip fracture with or without a bone density test, any clinical vertebral or spine, proximal humerus, which is your upper arm, or pelvis fracture in a patient with osteopenia is considered a diagnosis of osteoporosis. And I would also add wrist fractures and other potential fractures in that mix as well. Incidental fracture of a vertebral body on radiographs. Vertebral fractures are the most common osteoporotic fractures. About 70% of these are asymptomatic or subclinical. If I took 165-year-old women with a CT scan of the lumbar spine or abdomen and reviewed it, I would probably find 8 to 10 compression fractures on that scan. That's a scary thought. FRAX, which I'll go over in a little bit, is a test that everyone can do. It predicts fracture risk in the 10-year period for any individual. It's country specific, and there are guidelines that I'll show you on how to do that. But a 3% greater risk of a hip fracture or a 20% greater risk of a non-hip fracture, major osteoporotic fracture at 10 years is a clinical diagnosis of osteoporosis. So, important, a prior fragility fracture or a low energy fracture, which is a fall from a standing height, a fracture that probably shouldn't occur in a normal boned individual, or a non-traumatic fracture is considered a diagnosis of osteoporosis. This is kind of a rough distribution of fractures in the United States that are fragility fractures. Think of the number 2 million, the nice round number. You can see that the vast majority of these fractures are spine fractures. And this is important because the cumulative risk of a new fracture after an initial fracture, particularly of the spine, is quite elevated. You can see it's about 25% higher in the first couple years. In fact, I can tell you from multiple data sources that if you have a spine, hip, pelvis, femur fracture, your chance of having another fracture in the next year is 10%. to 12%. 1 out of 10, 1 out of 8. That's also a very high number, but it goes up considerably the more years you go out for that initial fracture. So a fragility fracture is akin to a heart attack of the skeleton. It's something that you take very seriously. The more vertebral fractures you have, the higher the risk of further fractures. And that is also a risk for very severe osteoporosis, multiple vertebral fractures. And they can occur in bunches. They don't have to occur one at a time. This is the Frax tool. The slide didn't show up really well here, but let me explain it. It's a calculation tool. It's continent and country specific. It includes mostly yes/no responses. You typically put sex, age, weight, height in, whether you've had a previous fragility fracture, whether your parent fractured a hip below the age of 85, current smoking status, current use of steroids, rheumatoid arthritis, and diabetes goes in that category as well. Secondary osteoporosis would be osteoporosis caused by another reason, such as cancer. And then you put the femoral neck bone density score in there. And then you get a score that will tell you your percent chance of having a major fracture in the next 10 years or a hip fracture in the next 10 years. And again, the risk above 20% or above for a major fracture or 3% above for a hip fracture characterizes you as having low bone density osteoporosis and need for further evaluation. 4 other factors for this questionnaire that haven't been added yet, but they've talked about doing so to make the analysis a little bit more comprehensive. 1 is the dose of glucocorticosteroids that someone takes. 2 is the amount of time someone has had diabetes. 3 is the presence of a new fracture rather than just a previous fracture. New fracture being in the last year to 2 years. And 4 would be someone with frequent falls. Someone with frequent falls is going to be very at risk for having a fracture no matter what their bone density is. Other ways to evaluate bone density. Trabecular bone score is a test that you can add with software to a DEXA program, and it looks at the volumetric structure of bone. Think of looking at Swiss cheese with a lot of holes in it, like we showed before on that electron micrograph picture, or Swiss cheese with everything filled in. So the thinness, you can see the picture on the bottom of the second row of the bone that's quite thin with the punched out holes in it compared to the illustration of the well-structured trabecular bone above. These are spinal bones that are seen. Remember, cancellous bone, trabecular bone is mostly the spine. You can also screen, as I mentioned, by looking at a CT scan. You can look at a CT scan and they have software embedded in the system where you can analyze the density of the bone. Typically, it's done at the L1 vertebral body, and it correlates quite nicely to DEXA scan reading. If you have a DEXA scan that you can't interpret properly, it was carried out with a bad reading, then you can use the CT test as another method to measure bone density. And below 100 suggests osteoporosis. Below 50, you would have difficulty having internal fixation hold if you were planning a spinal surgery. So this has become an important test for those folks that are contemplating spine surgery. It is a test, it's an adjunct to the bone density test. And this is what it looks like when you do it. It takes 5 minutes to do this with a CT scan, and the readings are extremely accurate. We use it all the time. You take that CT scan one step further and you use software that was developed out of California called biomechanical computerized tomography. And you can also get a density measurement, but this software actually simulates a force or a fracture event on a vertebral body and gives you a strength measurement of what that bone would hold up to as far as a force. So it's very accurate additionally in talking about the quality of the bone. And this is what, well, here, I'll show you what it looks like. I'll go back. But this is what the test looks like when you're applying the force to the bone. It's done via computer. It's done on a patient's normal CT scan. And when that bone breaks with the computer software, that's where it's considered to be fragile with the amount of force that's required. So a high-risk patient would be if a patient tests positive for fragile bone strength or bone mineral density defined osteoporosis, or both at either the hip or the spine. Osteoporosis also has secondary causes, and you can see them all listed above. And I'll go over some of them, but many are related to nutrition: calcium, vitamin D, minerals, chronic alcohol use, also smoking. Cancers can cause disruptions in the bone function. Malabsorption and gastric surgery or bariatric surgery are very commonly associated with osteoporosis. Things such as diabetes or hyperparathyroidism as well. I'll leave this up for a while so you can look at the list. Chronic illnesses: kidney, liver, lung. We have a number of kidney, liver, and lung transplantations in our clinic that we treat. Medications are also associated with bone loss, and this is the complete list of medicines. You can see there are numerous that are associated with low bone density. In particular, cancer therapeutic drugs such as aromatase inhibitors, and also Lupron for men for prostate cancer. Steroids, as we mentioned before, methotrexate, lithium, heparin, and other blood thinners are very commonly used. Aluminum-containing antacids. Again, I'll leave this list up on the so you can look at it. There's a number of medicines that can be associated with increased bone turnover, bone loss. Cancer. Most cancer treatments promote bone loss either directly by decreasing osteoblast activity or bone formation, or increasing osteoblast or decreasing osteoblast formation. That should be osteoclast there. Indirect effects include hypogonadism and kidney impairment. I will tell you this: with many of the cancers, and the cancer people will tell you about this, once you're diagnosed with a cancer, the inflammatory response of the cancer to your system produces bone loss, increased bone turnover before any cancer treatment is started. And that includes immunotherapy or chemotherapy. And based on 2019 data, there's at least 16 million cancer survivors in the US. And again, the treatments are associated with bone loss, and cancer itself is associated with bone loss. And the two largest groups of survivors are women with early stage breast cancer and men with non-metastatic prostate cancer. And you can see what the medicines for prevention typically can do in these circumstances: the aromatase inhibitors for women, and Lupron and medicines such as that for men with prostate cancer. This is the bone loss with various cancer therapies. And you can look at early menopausal women, about 2% a year, and look at what an aromatase inhibitor AI therapy does. Look further down and see what androgen deprivation therapy does. That would be someone with prostate cancer on treatment. And then ovarian failure due to chemotherapy, frightening. One other thing that I'll mention with bone loss is that in outer space, bone loss is 1% a month untreated currently. And we still don't have a good handle on how to prevent that. And that was primarily gained from a number of studies that have been done, but particularly Scott Kelly, who was up there for a year with his twin brother on Earth. 1% a month bone loss in space for most individuals. Bariatric surgery. This is research out of Boston. Look at the Roux-en-Y gastric bypass on the left. 5 to 7% spinal bone loss at 2 years and 7 to 10% hip bone loss, with a 70% increase of any fracture and a twofold increase in hip fracture. The gastric band seems to be fairly well tolerated as far as bone health. The sleeve gastrectomy, still a little bit of research to be done. The bottom part of the slide says possibly no change in risk of fracture. I think that has been dispelled now. There is an increased risk of fracture with the sleeve gastrectomy. Nutrition. People ask all the time about nutrition. I think a well-balanced diet is important. The vitamins and minerals that are listed above are important, and most people will get these in a balanced diet. We typically concentrate on vitamin K, magnesium, potassium as phosphorus. Those would be the big ones. Basically the nutrition to keep the bone health. you need a well-balanced diet. And a lot of the osteoporosis that's secondary, particularly in men, is related to poor nutrition. National Osteoporosis Foundation recommends these 3 steps for bone health. Aim to get the recommended daily amount of calcium you need from food first and supplement only as needed to make up a shortfall. And that would be about 1,200 milligrams a day for postmenopausal women. Much of that you get in the diet, and whatever you don't get in the diet, you can balance out with supplements. The 2 most common supplements are calcium carbonate and calcium citrate. Calcium carbonate is typically the most common. It's a mineral that you take with or after eating because it's not absorbed properly and it can upset the stomach. It can also cause kidney stones in some people. Calcium citrate is much better tolerated. It's a little bit more expensive. That would be Citracal. It can be used with a history of kidney stones. It can be taken anytime. So 1,200 is the amount per day. Maintain an overall healthy lifestyle by eating plenty of fruits, vegetables, exercising, and not smoking or drinking too much alcohol. If you're diagnosed with osteoporosis, work with your healthcare provider to determine an appropriate treatment plan, which includes calcium, vitamin D, safe exercise, and medication. Follow your plan and consult with your healthcare provider before deciding to stop taking supplements or medication. Vitamin D, most of us get through the sun, not in Pittsburgh, until after Easter, and then again after Labor Day, we don't get it. You can supplement it, and typically we recommend D3 over the counter. Also should be taken with food. Anywhere from 400 to 2,000 milligrams daily. No one has got the magic number. I take 1,000 milligrams daily. You can't really overdose on vitamin D. Vitamin D helps to absorb calcium. It can also help with fall prevention and maintaining muscle homeostasis and function. There are a lot of additional effects with it, but the main effect is to get calcium into the system with vitamin D. It is measured by a blood test, typically in nanograms per milliliter. The number we like to have you at is 40. Borderline is 30. Low is definitely under 30 and into the 20 range. And again, calcium, 1,200 milligrams a day. Most of you get that in your diet. Whatever you don't diet, you can get in the diet. You can supplement. Vitamin D, NOF recommends 400 to 800 milligrams daily. I tell people 400 to 1,000 to 2,000. Again, you can't really take too much vitamin D. You can try, but it's hard to do. Exercise and bone health. Evidence confirms that physical activity and exercise have multiple potential benefits for those with osteoporosis. Exercise may modestly benefit bone strength. Remember that, modestly, which means a little bit, not a great deal. It can never hurt. You can improve muscle strength. You can improve balance. You can improve posture. You can improve pain with the right exercise. And what can you do? Weight-bearing exercises are typically the ones that we have in mind to promote bone health. That's why space and bone loss is so important, because you're non-weight-bearing with the gravity effect being eliminated in space. Brisk walking, 3 to 4 miles an hour. Regular walking is typically not a lot of force. Jogging or running, sports that are listed. Stair climbing, which I wouldn't recommend for people with bad hips and bad knees. Dancing. Exercises such as yoga, Pilates, weight machines, free weights, resistance band, using your own weight. All these should be used with caution, particularly if you have low bone density or osteoporosis, and probably should consult with an exercise provider that's well-versed in bone health or a physician before starting any exercise program. Balance training can improve balance and help prevent falls as well. We actually teach balance and fall prevention with our Bone Fit Physical Therapy Osteoporosis program through the Allegheny Health Network. Doing it on your own is a little bit more challenging, but if you've got guidelines and what to do and things to do at home, we can certainly teach you that. So now we get to the high-risk definition of osteoporosis. And this has come out in the endocrine guidelines since 2020. And we've talked about a little bit so far. A high risk, obviously, is a T-score at any of those areas that I mentioned, less than 2.5 standard deviations below the norm, which would be a 30-year-old normal female. A prior hip or vertebral fracture, and I would suggest other fractures potentially as well, is a high-risk definition of osteoporosis. Or a FRAX score of 20% for a major osteoporotic fracture, or 3% for a hip fracture at 10 years. Very high risk is a T-score of -2.5 with a fragility fracture, or a T-score at any of those areas below -3 standard deviations. A fracture while on other approved therapy, someone that's been treated for osteoporosis with, say, Fosamax, and then breaks a hip. That's a failure of treatment. Multiple vertebral fractures, which I mentioned, which would be more than one, or a severe vertebral fracture. Vertebral fracture is think of a vertebra as the building block, and the building block gets crushed. And if the building block gets crushed more than 40%, that's a severe compression fracture. FRAX score greater than 30% at major osteoporotic, or 4.5 at the hip range, and a high fall risk. Someone that falls off it is also considered a very high risk and needs increased consideration for management and more aggressive management for osteoporosis. One question that I didn't answer earlier is that DEXA scans are typically done every 2 years for monitoring bone health, and they can be done at quicker intervals if you're looking at a response to treatment in someone with very severe osteoporosis. But for most folks, if you're monitoring someone with osteopenia or osteoporosis or on therapy, you would be doing the test every 2 years. If you've had a normal DEXA scan and confident it's normal by someone looking at the scan and making sure it's okay, then you can probably go at much greater intervals than every 2 years. So here are the questions that we talked about at the beginning. What is bone density and why is it important? What are the differences between osteoporosis and osteopenia? What are the main components of healthy bones? How does bone remodeling work? What are the risk factors for weak bones? What are the signs and symptoms of weak bones? How can I improve my bone health? What foods are good for bone health? What is the role of vitamin D in bone health? Is weight-bearing exercise really that important? And how often should I get my bone density checked? Thank you.
That was wonderful. Thank you so much. If you don't mind going to the next slide, we'll start to get into our Q&A. Oh, did you want to speak on this?
Just that, wish us a happy anniversary. It's 5 years this week that we started this clinic. This is kind of an older slide. I think we're well above 80% now of patients that accepted pharmacologic treatment, and the national average is 23%. Only about 4% declined medication treatment, and only about 2% stopped because of medication side effects or other issues. It's not 12,000 patients or 1,200 patients anymore. It's 5,000 patient visits, and we apparently have an 1,100 patient waiting list to get in to see us right now. We just got approved for another provider. Our clinic is nurse practitioner led. I see a couple patients a week as well, just to help with the overflow. We have 4 physicians that are, quote, physician champions with the program as well. And we're very, very pleased that the progress we've made. We're the only clinic like it in Western Pennsylvania, and no signs of us slowing down.
Thank you. And do you mind going one more slide forward? Just in case anyone needs to drop, just wanted to put this information up there if you want to learn more about the osteoporosis clinic, schedule an appointment, or if you'd like to join us for an upcoming group chat, we have pelvic health that will occur in May. So getting into the questions, we have a lot about supplements, so I'll kind of go through them a few at a time. If somebody cannot take mineral supplements because of kidney stones, is there anything else you recommend they could take to improve bone density?
Well, again, with kidney stones, you can take calcium citrate. So you can do that. And again, most of the calcium you're going to get is through your diet. So a well-balanced diet will take care of the other minerals as well. But calcium citrate can be used with a history of kidney stones. That's the calcium that the American Academy of Orthopedic Surgery recommends. Vitamin D will have no bearing on kidney stones at all. Vitamin D3 over the counter, very easy to take. I think everybody in Pittsburgh, frankly, should be taking a little bit of vitamin D supplement.
And then kind of transitioning to calcium, what do you think about calcium malate as a supplement? And does the body only absorb 300 milligrams of calcium at a time? And if so, are multiple doses a day needed?
I don't know much about that calcium supplement, but calcium, other than citrate, is absorbed typically with food or after eating. So you're not going to get the entire amount absorbed. People that have malabsorption problems, celiac disease, previous abdominal gastric surgery, other gastric issues are not going to get as much calcium absorbed into the body. If you have low vitamin D, again, that's kind of the facilitator for getting calcium into the body. So vitamin D should be normalized. That would help as well. That, in fact, with people that have had lower calcium, fixing the vitamin D probably more than 50% of the time is the solution to making sure the absorption is good.
Does potassium have an impact on absorption?
Pardon?
Does potassium have an impact on calcium absorption?
What has an impact on it?
Does potassium?
I'm not sure.
And is there any way to increase vitamin D levels if supplements do not work?
Yeah, we actually have one patient who had difficulty with supplements, and there's an intravenous infusion, but I can't comment much on it because we work with endocrinology with this patient as well, and I don't know how effective that is as well. But it's very, very few and far between where supplements won't work.
And does taking collagen strengthen bones?
Not really.
Should people take calcium Oh, sorry. Go ahead.
It won't hurt, but it won't help. You got probably a good amount of collagen unless you have osteogenesis imperfecta, but you've got to mineralize that collagen. So again, that slide that I showed with the arrows going around, that's the whole process. So it's only one step in the process.
And when taking calcium supplements, is it recommended to be on an empty stomach with food, or does it not matter?
Well, again, with calcium carbonate, you want to take it with food or after. Calcium citrate doesn't matter when you take it.
I was currently diagnosed with osteopenia. Is there a way to slow this down?
Well, as we mentioned, osteopenia is a diagnosis based on DEXA scan only. And you want to look at all the other factors involved, whether you've had a fracture, whether your FRAX score is high. If you've had a CT scan, maybe you've got evidence of Hounsfield units that are low in the lumbar spine. So osteopenia is strictly a DEXA scan. It should be looked at very closely. And you want to not only see what the level is on a DEXA scan, but you want to see if there's any changes from one DEXA scan to another. DEXA scans can be compared at 2-year intervals, and they need to be done at the same location, same computer software, and same technique. So I tell people I can look at reports all day long, but I want to see the actual pictures to go over it. And your provider should do that. They should look at the actual pictures. They should review them with you. If you don't get the answers you want, then you come to us and we give them to you.
And then another question, is there a particular brand of supplements you like?
I think multivitamin is fine, but just a good balanced diet is really the best. And vitamin D3 over the counter is the one I take. I don't think there's any big difference in any of the makers of that at all. Again, calcium citrate would be my preference, even though it's a little bit more expensive because you can take it on an empty stomach and it doesn't affect kidney stones. I take B12 occasionally too, but that's just personal preference.
Mm-hmm. Is working out on a mini trampoline considered a weight-bearing exercise?
The Academy of Orthopedic Surgery has a lot of literature on trampolines. Probably a little bit, but man, you're risking doing other harm as far as fractures. And that would not be an osteoporotic fracture. That would be a traumatic fracture. I've seen too many people with neck injuries from trampolines.
Does whether or not you've had children affect your risk of osteoporosis?
There is an osteoporosis associated with pregnancy that typically can be severe, but then reverses itself. And that's rare too. So typically, no, not having, I mean, whether you have 1 child or 10 children, that's usually not associated with osteoporosis. It's the loss of estrogen, and a lot of the osteoporosis is genetic, related to family history.
Is there any way for elderly people to increase their bone mass?
Yeah, as I said, with exercise, you can increase it a little bit, okay? But think of that slide I showed before with the hump when you form bone up to age 29 to 30 years of age, and then it goes down. That's like a bank account, okay? So once you get low bone density, and say you've been going down much faster and you're in the osteoporotic range or the severe osteoporotic range, you're overdrawn out of your savings account. And you're not going to be able to do an investment to get that money back. You're going to have to look at other methods to do that. Bone can modestly, exercise can modestly increase bone formation, but it's not huge amounts, no matter what people online try to tell you about the different programs. If those programs are really, really good, then the space program would be using them for all the astronauts. And guess what? They're not. So if you get to a certain point, your bank account is overdrawn. The only way to increase bone mass is through the medicines that we have out there.
I was doing exercises like squats, lunges, pies, etc. Are they weight-bearing exercises?
They are. The squats and lunges are great weight-bearing exercises, but they're terrible for the knees and hips. There's so many better things that you can do than squats or lunges. I can't stand squats or lunges or burpees at age 65.
Does HRT prevent low bone density?
Yes. Hormone replacement therapy does do that. And it's actually quite effective. It is a medicine that is a anti-resorbative. So it's similar to things like Fosamax and Reclass. It prevents the osteoclast from breaking down bone. It typically is very effective in the first few years after menopause. As I showed you, women lose about 2% to 2.5% of their bone mass in the first couple of years after menopause. I'm going to give you a long answer here. The risk of using hormone replacement therapy as far as cancer have pretty much been dispelled for people that are in the younger ages, particularly under age 60 or 70. You still want to use them with caution. I will tell you that if you do hormone replacement therapy and you come off, then the bone does rapidly turn over again with bone breakdown. But hormone replacement therapy is an excellent medicine to prevent bone loss, particularly in the initial periods after menopause. It has other benefits as well, obviously. So again, that's a whole other lecture that I have, but there's a lot of good research out there now if you want to look at it, particularly at the Bone Health and Osteoporosis Foundation website, BHOF.
Kind of going off of that, instead of squats or lunges, is there some resource you recommend people can go to find good exercises that they can start doing?
Bone Health and Osteoporosis Foundation has a great website as far as exercises. Bone Fit is another program that's out of Canada. That's the one our physical therapists use. I mean, simple things like a bike or elliptical are extremely good. And you're not pounding on, you can do it with arthritis. You're not pounding on your legs like you would be on a treadmill or running. So yeah, that's what I would recommend.
Thank you. What are your thoughts on Prolia versus Invinity treatments?
That's a whole other discussion. They're totally different medicines. Prolia is a medicine that prevents bone from breaking down, and it is done 2 shots a year. Invinity is a very potent medicine to increase bone formation, but it also has a dual effect of stopping bone from breaking down. Evenity is something that would be used in someone with severe osteoporosis or at high risk for fracture, very high risk for fracture. They're totally different medicines. So again, when we see you in the clinic and we talk about bone health, not everybody's a candidate for medicine, nor do we make everybody go on medicine. But we go through the risks and benefits of each of the medications that are out there. And if it's appropriate, we try to define what's the best fit for you. It's not cookbook. Everybody is different. Everybody's individualized.
We had a similar question asking how you determine if a risk from a treatment outweighs the side effects and efficacy. So I think that kind of fits in there.
We go through that analysis with everyone in the office on a point by point basis. But I will tell you this, the risk of a fracture, particularly a hip fracture, dwarfs the risk of what the medicines can do as far as risk.
And what are the best strategies for preventing falls, especially in individuals with balance problems or visual impairment?
That's a great question. I think seeing a physical therapist initially that can do baseline testing and do some teaching strategies for you are very important. As I mentioned in my talk, doing the balance exercises and things on your own can be a little bit scary and a little bit daunting to do that. I think a therapist that is very well versed in teaching some of the strategies, and it may not be more than 1 to 3 visits to the physical therapist, but they can teach you some of the strategies that can help. And we work with people all the time with balance problems, from inner ear stuff, from medicines, from Parkinson's disease, for example. Excellent question.
If someone has been diagnosed with cancer but did not need chemo as part of their treatment, will their bones still break down quicker?
Not necessarily. I'm in that boat. So with prostate cancer, with surgical treatment, and not necessarily the case. But if you've got a family history of osteoporosis and other risk factors, then that can certainly be something to consider. But cancer itself that's been treated and is in remission through surgery, typically it's not a big effect. But then again, you can monitor these things with repeat DEXA scans and other tests that I mentioned too. And that can be done through your primary care provider as well as one of the osteoporosis professionals.
Does finding the root cause of someone's osteoporosis, can that impact the treatment?
Yeah. As I mentioned, I've listed all those secondary causes, and many can be related to simple things like nutrition, and a good percentage can be related to things like parathyroid abnormalities with increased parathyroid hormone or vitamin D deficiency. We see a lot of young people that have bad bones, and more than 50% of the time, it's a factor that can be treated like a secondary factor. And vitamin D is one of the more important ones with deficiency, that once it's corrected, it changes a lot of things for the better. Not only the calcium absorption, but general health, muscle strength, fall prevention, all that.
And how does somebody's weight affect their bone health?
I would say this, low bone density is more classically associated with someone that's tall, thin, Scandinavian, white complexion, but obese folks can get osteoporosis as well. And a lot of that is genetic related, but again, it can be acquired with the typical surgeries that we discuss, particularly the Roux-en-Y gastric bypass surgery. So being heavy does not give you a pass to say, I don't have osteoporosis.
And I'll just make a comment really quick. If you have a question about how a certain medication might impact either your condition or another medication, we recommend that you follow up specifically with your PCP just for more individualized advice. I lost my question. If someone has a sedentary desk job, how can they incorporate bone strengthening activities into their daily routine?
That's a tough one. I've had people put that little bike beneath the desk and all,
Yeah.
and it's a good question because 95% of people have a sedentary or sitting job most of the time. I'm lucky in medicine, you don't. We're on our feet and doing physical activity, particularly in orthopedics. But you probably got to incorporate an outside program exercise, and it doesn't have to be a lot. 15 to 30 minutes of some weight bearing exercise um, uh, a week is fine. Gardening is a weight bearing exercise. Okay, vigorous walking, as I said, 3 to 4 miles an hour is a good enough exercise. And a little bit of free weights is fine too. Bike elliptical with a little resistance is fine as well. But at work, it's going to be very difficult to do that. If you do a 4 mile an hour walk at work and come back all sweaty, that's not really good.
Mhm. And just a trigger warning, I'm going to ask a question that's relating to eating disorders. If that's a trigger for you, maybe you can mute your speakers. Can a history of anorexia or other eating disorders cause irreversible bone damage even after healing and weight restoration?
I missed the last part of the question. Let me answer the first part
Okay.
first. Yes, anorexia and the female triad, as you saw with the bone formation, the way it peaks when you're 29 to 30 years old age. If you have something like that at a young age and you don't build, the big amount of bone that you're supposed to, then it's going to be irreversible to some degree because you're not going to bank as much as you could have if everything was normal. So cancer treatments at age, 10 to 15, anorexia at that age, gender reassignment surgery at that age can be very, very detrimental to long-term bone health because you're not banking as much bone as you should. Your bank account's going to get overdrawn when you're a lot younger. Now, there was a second part to that question. I didn't hear it.
It said even if you heal fully and return to your weight restoration.
Yes, as I mentioned just now, that is true. You can have irreversible. So my primary care physician talked about it 30 years ago that he starts osteoporosis consultation with kids when they're in, their late first decade, early teens, as far as the appropriate nutrition, the appropriate exercise, to bank as much bone as possible through good diet, through good exercise, avoiding some bad habits. Because once you hit 29, 30, then that's about it as far as the max that you're going to gain.
We're down to our few final questions. So if you were planning on asking one, go ahead and throw it in the chat. If not, we'll wrap up shortly. This is kind of funny. Does excessive coffee consumption impact bone health? And if so, how much is too much?
Yes, it does. And no, I don't know how much is too much. Um, my nurses, when they do the history, always record how many cups of caffeine people drink a day. I don't think 2 cups to 3 cups of coffee a day is going to be a big deal.
Good news. One on a good note. All right. Well, that was wonderful. Thank you so much for being here with us and sharing your information. And thank you, everyone who asked a question. We appreciate you being here and hope you'll join us for another episode of the group chat. Have a great day, everyone.
Take care.